For decades, medical researchers studied male lab mice almost exclusively, building human health baselines on just half the population. That blind spot left a massive gap in what medicine knows about female bodies. Jonquilyn Hill traces how this history of exclusion created a void that online influencers now exploit around perimenopause. Reading that next to Anissa Durham's reporting brings the consequences straight into the modern exam room. Durham looks at a misunderstood metabolic condition, showing how racial bias and outdated science delay diagnoses for Black and Latina women. It is worth pausing on what happens when the medical establishment looks away, and who pays the price when patients are left to find answers themselves. For generations, the medical establishment treated women as just small men, brushing off their symptoms as hysteria. In a piece published just this week, Jonquilyn Hill traces how that historical exclusion created a massive blind spot. Listen for the moment she connects this long legacy of neglect directly to modern social media feeds, pointing out that almost half of Americans now turn to uncredentialed online influencers just to understand their own bodies.
Medicine has come a long way. We are living longer than ever. We have eradicated diseases that once seemed like a certain death sentence, and new improvements are constantly being made to our quality of life. But despite all the advances, there's a huge gap in women's health. I think there's such an interconnectedness between society, culture, medicine, and science, Dr. Elizabeth Komen told Vox. She's a medical oncologist who specializes in breast cancer and an associate professor at NYU Langone. She says medicine often mirrors what's happening in society at large. For many societies across the globe, women did not have equal agency or power over their bodies, and that's really reflected in the history of medicine. Why it took so long to talk about perimenopause? For too long, women's health was treated as an afterthought. We still haven't caught up. It's reflected in medicine's present, too. The share of women with heart disease in the United States is rising. There's a cultural backlash and skepticism surrounding birth control. And almost half Americans are turning to social media influencers, many of whom aren't credentialed, for medical information. Why is there such a disconnect when it comes to healthcare for women? And what will it take for it to end? We find out on this week's episode of Vox's weekly call-in podcast, Explain It to Me. Below is an excerpt of my conversation with Evans, edited for length and clarity. You can listen to the full episode on Apple Podcasts, Spotify, or wherever you get your podcasts. If you'd like to submit a question, send an email to askvox@vox.com or call 1-800-618-8545. We are at this point where we know more about our bodies than we ever have before.
Sometimes you go to the doctor and it feels like they're still catching up on some pretty basic aspects of women's health. Why does it feel that way? Because it's true. It takes a long time for medical science to catch up with the glaring gaps in our healthcare system. The gaps are not just about the obvious women's health issues. We focus a lot on breast cancer. We focus a lot on reproductive function or our gynecological needs. But the gaps exist head to toe, from our neurologic care, our gastroenterology care, how our hearts function, how our immune system functions, how our joints function. The gaps are real, and the experiences are real. Can you walk me through some of the history? What did it look like to study women's health before the 20th century? What were we dealing with? When we think about modern medicine today and these specialties of urology, gastroenterology, they really didn't exist before the 1900s at all. Those are relatively new concepts. For much of the history of medicine, at least in the Western world, the idea was that at best, we were small men, and at worst, there were many ridiculous diagnoses, like hysteria, and a long legacy of dismissing women's medical needs, because we were largely not taken care of by women. Those women that were caregivers in the history of medicine, whether it was the midwives or other types of healers, were largely pushed out of medicine as it became codified, and the idea of medical science really came to rise in the late 19th century. So I'm guessing that they weren't really talking about menopause at the time, let alone perimenopause. Perimenopause wasn't even discussed. That's a relatively new term and new part of our lexicon when it comes to lay discussion and the public at large.
With respect to menopause, one of the famous physicians, Roger Wilson, wrote a book called Feminine Forever and referred to women going through menopause as vapid cows. He was the one that advocated in the 1960s and 70s for women to be on hormone replacement therapy. But understand that in the 1850s, it's not like people really were wildly aware of what estrogen and testosterone and progesterone did. These are all relatively new ideas, the concept of hormones and how they can travel in our body. And again, we have a long way to go. I read that women were rarely included in clinical trials until the National Institutes of Health mandated it in 1993. I find that so surprising. Why were women missing there? Well, these studies were not designed with women in mind. Some of the massive cardiology studies for drugs that we use day in and day out were done on thousands of men and not women. There is so much to that history, including the animal models on which many of these drugs were developed. In order to develop a drug, often they are developed on mouse models first. It wasn't until 2016 that you were even required to state the sex of the mice that you were studying. In many of these instances, female mice were not even included in drug development. Oh my gosh, even the mice? How were these hormones marketed to people when hormone replacement therapy first became a thing? It depends on which advertisements that you look at. If you look at advertisements of women in the 1950s, 60s, and 70s, a lot of women were being prescribed anti-anxiety medicine. Can't manage your household at home? Don't want to take care of your kids? Here's what will sedate you and at least make you able to prepare breakfast for your husband. It's really shocking, and yet not that surprising. If you look at Instagram today, are we really that far off from what gets marketed to women? Women sink billions of dollars probably into sham supplements and sham treatments because they don't feel cared for when they go to the doctor. And what fills that space? A lot of people trying to market things that have no proven evidence. I think it's really interesting that at one point, hormone replacement therapy was this big thing. Because I feel like growing up in the 90s and 2000s, hearing women who are older than me speak, they were kind of anti-hormones. How did the pendulum swing that way? Well, the pendulum has swung in wildly different directions. At first, it was every woman needs to be on it, and there were wildly successful sales. Then there was the women's health study that exaggerated the risk of breast cancer. Understandably, women were terrified. They were told by the media and by reputable scientists that these risks were significantly high and that they could not be on it, and we didn't leave them with any alternatives. Now, we've become much more granular about what we know and what we don't know, but I still think we're far behind on the science. There's still a lot that we need to learn, but fortunately, an understanding of the prior studies and what their limitations are has come to light. There are all these gaps in trust in treatment. There's going to be a fair amount of snake oil out there, but are there ways that this moment is actually driving better treatment for women? I'm so grateful that we're talking about it, but I am terrified of what I see from influencers on Instagram.
People can fake their knowledge. There's so much fake imagery and information that is out there. I wish that we could invest this in quality science, which is long and laborious and painful at times, but gives us the quality answers that we need. Every day I see the consequences of fake information online, whether it's an incredible loss of financial resources or just wasting money so that you could buy a nice pair of shoes. That would make you feel better than the ridiculous thing online that's overpromising and underdelivering. The fear-mongering is out of control. What do you think it will take to trust their doctors again, rather than turning to the treatments they're being sold online that might be dangerous? What will it take for them to feel good about the interactions they're having at the doctor's office? I think it's going to be really challenging. We can't blame patients because we've done them a disservice. Medicine has fragmented the care of many patients, not just women, but men as well. We have to build a healthcare system that allows for time to be with patients and really holds space for them. I think that's where the trust is really going to be built. Because at the end of the day, despite all the technology that's available, medicine is about human-to-human care. That is what everybody wants to be treated as, a human, to be seen and heard in the ways that you can't just reduce a body to biology.
Jonquilyn Hill ends with a frustrating image. Patients sitting in a doctor's office today, realizing the person in the white coat is still guessing about basic female biology. For decades, researchers treated women as small men, leaving entire medical fields playing catch-up. What jumps out reading Anissa Durham next is how that broad historical blind spot plays out in a specific hospital room. Durham looks at a condition recently renamed polyendocrine metabolic ovarian syndrome, or PMOS. Read alongside Hill, Durham's reporting shows what happens when a baseline ignorance about female bodies collides with racial bias. Hill points out that doctors historically dismissed women's pain as hysteria. Durham picks up that thread and shows how that dismissal mutates for Black and Latina women, who are often assumed to have a higher pain tolerance. The interesting thing is how the two pieces lock together. Hill explains why the medical system lacks data on women in general, while Durham reveals who pays the highest price for that missing information. Patients like Bontley Mocha Maliki, who spent years waiting for someone to treat her daily pain as real.
Bontley Mocha Maliki starts and ends every day in pain. The 32-year-old Atlanta resident was diagnosed with endometriosis in 2019. A year later came fibroids. Then in 2024, she was diagnosed with a condition now called polyendocrine metabolic ovarian syndrome. If someone is at a 0, my pain is at a 3 every day, and then it's only up from there, she said. PMOS was known as polycystic ovarian syndrome until about 2 months ago, when it was renamed to better capture its symptoms and to allow for a possible male form of the syndrome. The hormone health issue typically starts around the time of the first menstrual cycle. Women with the condition commonly experience irregular periods, facial hair, pain, weight gain, and what were assumed to be ovarian cysts. Mocha Maliki said the syndrome also sent her into bouts of depression. Experts hope the new name will increase recognition and lead to faster diagnosis of the syndrome. Women of color, in particular, experience double the prevalence of PMOS compared to white women and often go undiagnosed. Black women are more likely to experience more severe symptoms like hirsutism and hypertension. Hispanic and Latino women experience more severe metabolic complications compared to other populations. Both groups of women experience delayed diagnosis, barriers to access health care, and low rates of health insurance coverage. They also have an increased risk of mood disorders. It's just been a roller coaster, Mocha Maliki said. I would feel really, really sad, more than usual. The pain has always consistently been there, but it was mostly the mood swings. At times, I'd even feel suicidal, and I felt just not myself. Last October, Mocha Maliki was constantly fatigued. Initially, she chalked it up to low iron or low vitamin D. Then, for 2 weeks, she felt like she was walking around with a weighted blanket. Suddenly, she felt a sharp pain on her right side. Maybe, she thought, an ectopic pregnancy or a punctured lung. Due to constant bouts of pain over the years, she knew this was different, but she still thought it was just a new kind of period pain. When she finally made it to the hospital, weeks later, doctors told her a cyst in her ovaries had ruptured. Shortly afterward, her fibroids came back. When it comes to Black women, we are expected to be more resilient, have a higher pain tolerance, and we tend to be overlooked a little bit more, she said. We usually will have a large group of Black women shouting from the mountaintops that this is what we're dealing with in the community. Every woman experiences different symptoms at different severities, said Margaret Lippincott, physician and director of the Multidisciplinary Care Center for Polyendocrine Metabolic Ovarian Syndrome at Massachusetts General Hospital. Women of color with PMOS are at an elevated risk for diabetes, high blood pressure, sleep apnea, high cholesterol, and pregnancy-related complications, including gestational diabetes and preeclampsia. A lot of the research on PMOS has not included women of color, she said. Unfortunately, the one thing we have learned from medical literature is that individuals of color are often not listened to. PCOS delayed diagnosis. More than 5 million women and girls of reproductive age in the United States live with PMOS. The World Health Organization estimates that up to 70% of people with the condition are undiagnosed. Helena Teed, a professor of women's health at Monash University in Australia who helped reassess the syndrome, said its new classification as an endocrine condition highlighted its potential impact on metabolism, cardiovascular function, skin, and mental health. This will lead to new ways of treating the condition, but it will take time, she said. With no single diagnostic test to confirm PCOS, symptoms often overlap with other endocrine disorders, and this exacerbates the toll on Black and Latina women. Currently, diagnostic guidelines are based on exclusions. Physicians check to see if a patient presents with 2 out of the 3 criteria: irregular or absent ovulation, hyperandrogenism, or ovaries with an accumulation of small follicles. The excess follicles that have grown on the ovaries, Lippincott explained, were once thought to be fluid-filled cysts, hence the syndrome's old name. Yet only about a quarter of women present with extra follicles, and research shows many physicians have gaps in knowledge when it comes to diagnosing and treating the condition. In one survey, more than 1/3 of physicians associated cysts on ovaries with PCOS. As a result, this long-standing miseducation delayed diagnosis, and including polycystic in the original name prompted physicians to focus on the cystic presentation of the condition, even when patients experienced the metabolic and fertility issues linked with PCOS. It was never about ovaries for me, Antaria Bruce, a women's health nurse practitioner in Houston, said. It was always about the metabolic dysfunction because I had suffered with weight gain, infertility, and hirsutism. Looking back, Bruce said, her symptoms started at 18. But the official diagnosis didn't come until she was 25. Soon after, she was prescribed metformin, a medication for type 2 diabetes that helps lower insulin and blood sugar levels and regulate menstrual cycles. Later, she switched to Farxiga, another type 2 diabetes drug. Then came birth control, and eventually she quit prescriptions altogether. One made her constantly use the bathroom, another gave her constant yeast infections, and the other didn't help with weight loss. It affected my confidence when it came to the vanity of things, the now 39-year-old said. It really affected me mentally and physically. Too big, too thin. Sudie Kamosi, a schoolteacher in Haines City, Florida, has struggled with her weight since childhood. The adults in her life constantly told her to lose weight, and she repeatedly tried. In her late teens, she noticed irregular, painful periods, fluctuating weight, and facial hair growth. Then at 24, she had a period for 3 months straight. She knew something was wrong. I refused to go to the doctor because every time I went for something, they exhibited a lot of weight stigma, she said. Eventually, she went to see a gynecologist who found cysts on her ovaries. As a result, Kamosi was diagnosed with PMOS, but she feels she should have been diagnosed earlier. In the last 11 years since her diagnosis, she's been prescribed birth control and metformin. Recently, her endocrinologist, neurologist, and pulmonologist on separate healthcare visits all recommended she try a GLP-1 medication. Kamosi declined because of her other health conditions and fear of side effects. I never bring up my weight, she said. Kamosi, now 35, said connecting with a nutritionist has significantly helped manage her condition.
Lippincott, the Massachusetts endocrinologist, said there are several issues underlying how physicians view weight. Obesity is not and has never been part of the diagnostic criteria of PCMOS, she said. Because PCMOS is a polygenic condition, there are multiple risk factors that overlap with weight gain, she explained. For example, many women with PCMOS have high fasting insulin levels, Lippincott said, no matter what their weight is. And many physicians know that long-term insulin resistance can contribute to weight gain. Alexis Brooks, a women's health dietitian in Washington, D.C., isn't surprised that physicians overlooked and underdiagnosed PCMOS patients living in larger bodies. She's treated more than 500 patients with PCMOS in the last 13 years, plus hundreds more who presented with symptoms but didn't have an official diagnosis. Yet it's not just women in larger bodies who are dismissed, she said. A term that is also thrown around is lean PCMOS, she said. Providers won't even think they have PCMOS because of the way they look. In her private practice, she decenters weight. Instead, she focuses on her patients' nutrition, balancing blood sugar levels, lowering inflammation, and supporting a healthy menstrual cycle.
I'm really glad the name change has happened, Brooke said. It doesn't change my approach, but I think it can change the way providers view it. Long live PCMOs. Now what? Andrea Medina Alvarado, a Texas policy advocate at the National Latina Institute for Reproductive Justice, was diagnosed with PCOS, now PCMOS, late last year. The 27-year-old struggled for 2 years with weight gain, hair growth, and the cost of accessing healthcare.
Now, with immigration and customs enforcement raids sweeping across the country, she said, many Latinos and other immigrant communities are afraid to leave their homes to go grocery shopping, access health care, or go to work. And under the One Big Beautiful Bill Act, millions are expected to lose access to Medicaid next year. She fears many Latina women without health insurance will continue to live with devastating symptoms and little relief. A lot of people didn't know what PCOS was, and that was if I was talking to people in English, let alone talking to people who are Spanish speakers, Medina Alvarado said. The general public isn't aware of PCOS because it hasn't been talked about that much. Now with the name change, it's a better reflection of the condition itself, but there needs to be a lot of messaging and conversations in communities. One way she hopes education will begin is through community healthcare workers. She also calls on social justice movement partners and Texas legislators to bring more awareness to PMOS. Lippincott noted that the need to inform more women of color about PMOS reflects the long-standing dismissal of women's health in general. We need to value women's health. We need to invest resources in research, education, and clinical support, she said. What you're seeing is a reflection that we have not done enough of that. Stats coverage of chronic health issues is supported by a grant from Bloomberg Philanthropies. Our financial supporters are not involved in any decisions about our journalism.
A missing female lab mouse decades ago eventually becomes a misdiagnosed patient today. What lingers after hearing these stories is how an empty space in medical data turns into an active hazard. That void gets filled by online salespeople peddling quick fixes, or by clinical biases that send Black and Latina women home with no answers. The science is finally starting to catch up, replacing old assumptions with actual biology. But a harder question remains. How does a patient trust a medical clinic that is only just beginning to learn how her body works?